The main area that we're focused on at the UC Davis Vascular Center is peripheral artery disease. We do a number of other different procedures and treat other patients, but the bulk of what we do here is critical limb ischemia, meaning patients that come in with such little blood flow to their toes or to their feet that they're at risk for losing their leg. It's sort of the extreme form of peripheral artery disease because when you look at the spectrum of arterial disease, it can be as early as asymptomatic arterial disease, where somebody is being worked up for their heart and they're found to have decreased blood flow to their feet. And then that spectrum can go all the way to the mid portion, which is called claudication. When people walk, they get pain in their calves, that hurts them, and that demonstrates that there's some type of blood flow limitation in their legs. The most extreme form is called critical limb ischemia, when even when the patient is sitting at rest, they don't get enough blood flow to their foot, so that they're really at risk for limb loss, and that's the biggest concern for patients. Most of the time these patients start with mild peripheral artery disease and they just adjust their lifestyle, so they stop walking as much. A lot of these patients have smoked or they have diabetes and other chronic conditions, and so they've changed their lifestyle over time so that it's very hard to pick up the fact that they have any arterial disease. We also see in patients that are older, somewhere between 75 and 85, what we've seen is that they can develop spontaneous arterial disease. And usually that's a product of just their age and the genetic changes that come about over time to the smaller arteries in the feet and in the lower leg. And we don't actually have a good reason as to why those patients develop arterial disease. Most of the time these patients are treated by internists because they have so many chronic medical conditions, or family practitioners. They'll have hypertension, they'll have high cholesterol, they may have heart disease to where they've had a heart attack or been treated with stents in their heart. And so picking up on the arterial disease in their legs is a little bit difficult. The other group of providers that that see these patients are endocrinologists because they deal with the diabetic patients. An assessment of the foot has been a push by the Institute of Medicine for assessing the feet in diabetic patients, where you test for neuropathy. But one of the things they haven't spent a lot of effort on is testing for arterial disease in these patients. And it's hard because a lot of times these patients will have normal ankle brachial index, which is a measure of the arterial flow at the ankle compared to the arms. That will actually be normal, but where they start to have a decrease in their perfusion is below the ankle and the toes. And so picking up on that takes a little bit more of an effort, sending them to a vascular lab that'll measure toe pressures. Most of the time we don't pick up on these things until it's too late. They develop a wound on their foot, and from there people are reactive. We react to the fact that now they have this wound, and now we have to do some procedure to improve their blood flow, and we may or may not be able to save their limb. And that's the concerning thing, is trying to find which population we can identify early and be proactive on those patients. Doing a pulse exam in patients can be very difficult. In a lot of these patients, they have edema or swelling in their legs, and that can make feeling the pulses incredibly difficult. We have a grading system for pulses, which is usually strong, diminished, and then not present. At the Vascular Center, for us, it's either they have a pulse or they don't. And when they don't have a pulse, we go on to examine their feet for arterial blood flow using the ankle brachial index. And it's a simple test actually that can be done in the clinic. You can train a medical assistant to do it. And that's really what is nice about the test, is that you don't have to have highly skilled personnel to do this. And when you're doing an ankle brachial index to test for the blood flow to the foot in a clinical based setting, we adjust it a little bit. When it's done in the vascular lab, it's more complete. You take the pressure in both the artery the posterior tibial artery and the dorsalis pedal artery, and you find out which one of those is lower, and you compare it to the brachial artery pressure. But when you're doing it in a clinical setting, you can listen with a Doppler to listen to what artery is the weakest and what artery is the strongest, and you can use that stronger artery and just do the pressure based on that. Podiatrists are critical. They really help us. They are the early people that see some of these wounds, but they're also the early preventative medicine folks for patients with lower extremity arterial disease. They're doing wound care. They're actually doing preventative care such as nail trimming and keeping an eye on patients' wounds. When patients have deformities in their foot, such as with diabetes, they're doing putting in implants or different cushioning devices to help offload the foot in a different way. Some of the bony reconstructions that can be done early, Achilles heel lengthenings for patients with deformities, straightening of the toes, or different things along those lines are all important. The problem is we don't have enough podiatrists, and we don't have enough people out there doing these things. The one thing I would say that even for podiatrists is performing some type of assessment of blood flow for patients, knowing if the patient has disease just to the level of the ankle, or if they have disease below the level of the ankle to the toe. Figuring that out really helps to determine which patients at the very high risk for limb loss.